medical story of a male of 72 years old who presents epigastric pain since December 2014. He is a former alcohol and tobacco consumer, and in April 2015 a gastroscopy showed a malignant tumor of the cardiac junction between 40 and 43 centimeter dental arches. Biopsies confirm the presence of the well-differentiated adenocarcinoma with a TNM classification of CT3, N0, M0, and CT scan. We keep the indication of EUS evaluation is retained. And so in this slide, we can see two major studies of Hassan in 2010 and Araujo in 2012 that studied the impact of EUS FNA in nasogastric cancer. They found a result of 42% and 36% of distant metastasis that changed the oncological management in 15 and 23%. It confirms that EUS FNA is a modality that should be integrated in the preoperative staging of gastric cancer.
We are going to perform the staging of this esophageal cancer. There was a stenosis, but we were able to pass because I'm using the SLIM scope from Pentax, the 3270 UK. So we passed without any problem, and now we are in the fundus of the stomach, and I'm going to check for the lesion. We use over the linear scope even for the staging of esophageal cancer. I think that the SLIM scope in this case is really a good instrument because we can pass very easily. We can safe pass the stricture, the stenosis. So I think it's a good choice. You can see here the lesion. So it is a very thickening esophageal wall, completely hypoechoic. So all the layers are completely involved by the lesion, and there is even the infiltration towards the periesophageal tissue. And there are some pathological lymph nodes around the cardiac lesion. You see this one.
This is another point because we've seen that the staging based on CT scan was an N0 lesion.
Yeah, exactly.
And this is clearly to state that AUS is clearly more sensitive for the detection of lymph node staging in these kind of lesions.
Yeah. And for sure, we check even the lymph nodes of the vascular station from the hepatic hilum. Now we check here. We are going towards the hepatic hilum. We can see this reactive node.
Do you find that elastography is helpful in assessing nodes in this situation?
Oh, elastography is of course useful. In this situation, the lymph nodes are obviously pathological lymph nodes because even the EUS findings are just, in this case, enough to define these lymph nodes as pathological.
But I fully agree with the question of elastography. I think it's very useful for lymph node staging in some cases when you have distant lymph nodes that can really make the change. It's a very good tool even to target which is the best node to FNA if this is needed.
Yeah.
And in certain circumstances, if you have a good agreement with your oncologist, maybe based on just on elastography, you can just take some decisions on the treatment options for the patient.
Yeah. So I just want to show you here, there are some pathological lymph nodes again. This is the diaphragm. There is no invasion, no infiltration of the diaphragm structure, even if it's go quite near. And now we check for the lymph node along the splenic vessels. Probably there is one small here, very small. And no lymph nodes at the splenic hilum.
Okay.
Yeah. Yes. So we can try to pull back the scope. Again, the lesion here.
This is another good image that Mara is showing us is the liver, because sometimes we have a very good access to left liver lobe for staging some of lesions. Not only esophageal cancer or gastric cancer, but also for lung cancer. It's very nice to have the option to take a look at the left liver lobes. Sometimes you can check very small, tiny lesions that can really make a complete change in the staging of the tumors.
Okay. So this is the aorta. The spine here and the azygos vein. This is the regular esophageal wall. Okay. We have obviously to check for any lymphadenopathy in the mediastinum.
You used to go from deep up when you do the staging in the esophagus. You start from stage 9 and go to see then subcarinal, then go to 4L, because there's some, we think it's more nicer to go from the deep part up, or just the opposite, because it's just some kind of cultures on the staging from.
No, we used to perform the staging from the esophageal lesion, so from the stomach, and then we come back to the proximal part of the esophagus and check for the mediastinum. I don't see any pathological lymph nodes here. This is the subclavia from the aortic arch.
So we will say that the lesion is at T3?
Yes, and 1, I would say. Yeah.
And without any distant diseases that we've checked in the distant organs.
I agree, yeah. This is a very nice picture with the scope just upon the cardias, the lesion here. This is the lumen of the esophagus.